Okay, so first of all, thank you for accepting to present and to share your expertise with us. You are a big asset to the journal, and you have a lot of experience with systematic reviews and meta-analysis. And I'm sure that many of the people connected and will have similar issues in going through many of the systematic reviews and meta-analysis that are currently being published. Most of the journals are very much interested in publishing systematic reviews and meta-analysis for multiple reasons. And I'm sure you're going to touch on these issues as you go through the talk. And we're going to leave at least 15 minutes at the end for people to ask questions and raise issues, if that's okay with you. Thanks again for agreeing to present and welcome. And the stage is yours. Please, Fahima, go ahead.
Yeah, absolutely. It's my pleasure. In fact, I remember when I was writing up my first systematic review, emailing you, Rodrigo, to get some extra data. So those of you who can't find data in papers when you're putting together a meta-analysis, don't be afraid to email authors, because some of them will be nice and send you some information. So it's a pleasure to be here. I figured what we would go through today is a broad overview that'll be relevant both for those in the audience who are trying to conduct systematic reviews and or meta-analyses, as well as those of you in the audience who review for journals. I think the tips I'm going to touch on for reviewers are actually extra relevant to readers or writers of systematic reviews, because obviously you don't just write these, you want to get them published. And so it'll give you a sense of what reviewers are looking out for when you send your papers to journals. Emma, I'll apologize, there are a lot of animations on my slides. Next slide. Next. So things that we're going to discuss today, one, how to conduct systematic reviews and really going through the steps as a broad overview, as well as, like I said, some of the common pitfalls at the review stage for those of you looking to publish or review for journals. Next. There are a number of things that we won't cover today. Meta-regression, next. Network meta-analyses, next. Bayesian and non-inferiority meta-analyses, next. And individual patient data meta-analyses. I would say that these are more advanced topics, and I'm happy to chat with anyone individually if these are things that you're undertaking. Next slide. Next. So anybody doing or reading a systematic review, JAMA has a number of papers on various approaches and various methodologies and things to consider when reading and writing these papers. So for systematic reviews, there's a user guide from JAMA that talks both about conducting systematic reviews and lays them out step by step. Next. As well as a guide for appraising systematic reviews and meta-analyses. And really, I've based a lot of my talk around the JAMA series. Next. And then, of course, anybody doing a systematic review, really, this is the holy grail, the Cochrane Handbook. This is freely available online and breaks down every step of your systematic review and really what the best practices are, whether or not you're doing a meta-analysis. So I would highly recommend that you all download this handbook and reference it quite a bit as you're putting together your papers. Next slide. These are the topics that are covered throughout the handbook. If you look at the core methods or part 2, this really breaks down each and every step of conducting a systematic review and really goes through the literature in detail on steps to do this well and make sure that you have a high quality systematic review. Next slide. So the first thing I wanted to talk about was broadly how to select a topic that's appropriate for a systematic review. Next. So I think before you put together systematic review, you really need to think of what the purpose is. And I would say that there are probably two main purposes of conducting systematic reviews. One is you really want to amalgamate the evidence that exists already and put it all together in one place. So this is highly relevant if you have a topic where there are a lot of studies and your goal is to put together a synthesis of all of that work. Next. But the other, and I would say probably the bigger reason to do a systematic review is highlighted here, and that's you really want a technique that's going to minimize bias by using pre-specified research questions and methods and uses reproducible methods. So I've highlighted three sets of words there: minimize bias, pre-specified, and reproducible, and you'll see those themes come out a bit throughout this talk. Next slide. So in finding the right topic, next. For those of you who are simply doing a systematic review, finding the right topic, as I said, includes narratively commenting on really the aggregate of all of the data that exists. But for those of you thinking about a meta-analysis, the goal in finding the correct topic is a bit different. Next. Where here, there are really two places where doing a meta-analysis is particularly helpful. One is the setting where a lot of the previous studies were small studies that lacked power. And so none of them really showed statistically significant differences. And your theory is that by combining the data and increasing your power, you'll be able to show a meaningful and statistical difference. The other time you might think about the utility of a meta-analysis is if you're trying to get a more precise estimate of the effect size of a certain intervention. Next slide. And so that brings me to how do you select the right question and how do you develop a question for a systematic review? Next slide. Many of you have probably seen this outline that applies to a lot of different types of studies, the PICO format. And this is relevant in the setting of systematic reviews as well, particularly as you think about the design and the eligibility criteria. So for those of you unfamiliar with this, things to consider: the population or who you're studying, the intervention, what is being studied, the control group, if you have a comparative systematic review, what are you studying the intervention against, and then what is the outcome of interest. Next slide. So as I mentioned or alluded to, your research question in that PICO format really governs the eligibility criteria that you're going to use for your study. Next. So as far as the peer, the participants, things to consider as you turn your question into eligibility criteria are thinking about how you're defining the disease in the participants. There might be relevant demographics. For example, you might want to just look at adults. You might just want to look at elderly patients. The setting might be important. Do you want to look at all hospitals? Do you want to look at a subset of hospitals, certain geographic areas? What are the diagnostic techniques that were used to define the disease? So not to define the intervention, but to define the disease itself. For example, in rectal cancer, were patients diagnosed with MR? And are there subsets of patients within broader studies that are going to be important to you? And identifying that early is important in trying to figure out the types of studies that you'll be looking for in your systematic review. Next. Next is considering the interventions, so both the intervention and the control and how you're defining those. And things to consider here are there variations in how you might measure an intervention that's relevant to your study? Are there differences in doses, in frequency, in timing, in the mode of delivery, or the administrator of that intervention? And are there studies that may have co-interventions that are relevant to you? Next. In thinking about the outcomes, the Cochrane Handbook actually states that you shouldn't use outcomes to define eligibility criteria, but obviously in some cases they are going to be particularly relevant. And so as you think about the outcomes that you're going to include in your review, you want to think about not just what the outcomes are, but when were they measured, who was measuring them, and how. And I've put a couple of examples there. So if you think about you're doing a review on something related to anastomotic leaks, that's your outcome. Well, are you looking at leaks that were diagnosed clinically or radiographically? And the same could apply if you're looking at, say, peristomal hernias. Are these all radiographic diagnoses or clinical diagnoses, or both? And also, how are you going to use that outcome in synthesis? It's always helpful to think about that well in advance. Next. And then other issues to consider are the time frame and the design. So when did the intervention that you're looking at come into practice? If it came into practice in 2010, there's no sense in designing a search that goes back to 2000 or earlier. Are there temporal trends in treatments changing over time that are going to affect any analyses you do? And you do want to consider up front whether the question you're asking has randomized data or could have randomized data. Because there will be some questions where it doesn't make sense to do a randomized study. And so from the outset, you might limit yourself to observational data. Next slide. So at this point, if you're a reviewer and you're looking at the question and the topic being asked, really what you want to ask yourself at the outset of reviewing these papers is, does the review explicitly address a sensible clinical question? Which means as the person writing the review, you want to be very clear about what the question is that's being addressed in your study. Next slide. So that brings us to designing the actual study itself and developing a protocol. Next slide. So I would argue that any systematic review should have a registered protocol, and that really is best practice. Next. So this is a screenshot of Prospero. Prospero is a great site. I put the link there. If you go to the site, you can register your own protocols. So really there are two options for registering protocols a priori. You can either use a site like Prospero, or there are also journals that will publish your protocol, with the advantage of the latter being that your protocol will get peer reviewed. The purpose of doing either of these things is to show readers that you have a transparent, unbiased process that you've gone through, and that you've thought about how you're going to handle various issues that come up in your review well in advance. And again, this helps minimize bias as you go through your review. Next slide. So this is a screenshot of what you're able to do with Prospero. So not only can you register your own protocols, but even before you start a study, you can enter the topic of what you're planning to write a systematic review on, and you can look at whether there are any similar systematic reviews and what the actual status of those studies are. And this might help prevent against duplication of studies and you wasting your time. So I'd really recommend doing that before you even get started. Next slide. And this is what a protocol, part of a protocol might look like. Some of them are far less detailed, but the idea being that you fill in each of these pre-specified boxes, and Prospero, as one example, tracks any changes that you make to the protocol when those changes were made, and you usually have to provide a justification. And so as a reviewer, you should be going back to that protocol if it has been registered to look at how many times it's been altered and why. Next slide. And I think at a minimum, as a reviewer, you should ask yourself, was the protocol registered a priori? And were any changes made to it? And was that tracked and explained? Next slide. I often see this as people describe their study design. This is a quote that I can pull out from numerous papers that get submitted to various journals. The study was conducted in accordance with Prisma guidelines. This is a huge red flag the minute I see it. And the issue here is in saying that a study was conducted, the keyword being conducted according to Prisma guidelines. The Prisma guidelines are reporting guidelines. They don't actually govern conduct of systematic reviews. And so when I see this sentence, it tells me that somebody has not read the Prisma guidelines and has not actually put thought into best practices around conduct of systematic reviews. So really, you should be conducting your study based on recommendations from authorities like the Cochrane Handbook, not according to Prisma guidelines. Next slide. So how do you design a search for a systematic review? Next. There are a few sources that you can use. One is bibliographic databases, and at the very least, you should probably use two of these. The most common ones are Embase and Medline, and there are a number of other ones. I've listed one other one here, CINAHL, which is a nursing literature database. Next. There are also registries, for example, clinical trial registries that you can search if you are including clinical trials in your study. And sometimes this is just helpful in saying that there are these ongoing trials, but sometimes these registries will actually point you in the direction of papers that you may not have come across through your bibliographic search. Next. And then the final recommendation is to consider the gray literature. And the extent to which you use this is going to be variable and based on the actual topic of your study. And certainly if data are sparse or it's a really fresh and evolving topic, I would recommend using the gray literature. And this includes, but isn't limited to, dissertations or theses, as well as looking up conference abstracts. One way to do this is just going through Google Scholar, say going through the first 10 pages of Google Scholar. Next slide. So some of the best practices as you're designing a search. Next. I would suggest using a librarian or information specialist to design your search for you, with input from you, of course. Next. And really the best practice beyond that is having peer-reviewed search strategies. So the ideal technique would be having an information specialist design your search, and then that specialist having your search strategy reviewed either formally through a publication or informally with their colleagues. Next. I see this quite often, people including outcomes as keywords in their search. I would really dissuade you from doing this because it will miss a lot of studies and will unnecessarily limit your scope. Next. Make sure to include the search strategy in the manuscript, and this is part of the Prisma checklist as well, and considered necessary by a number of journals. Next. And then finally, best practices include updating your search if it's been more than 12 months since the search was performed. It obviously takes a long time to conduct a systematic review. It's not uncommon that it takes you over a year to go through the entire process. And if that's the case, just rerun the search right before you submit the paper, just to make sure that there are no new relevant papers. Next slide. Then as a reviewer, what you want to ask yourself about the search is really whether the relevant studies or whether the search was appropriately exhaustive. And I consider sensitivity versus precision. Really at the search stage, you want to make sure that the person doing the study has been overly sensitive, meaning they've tried to capture as much as they can without being unnecessarily precise. So the example I gave you earlier was including outcomes as keywords. You really want to keep an open and broad search and narrow things down the road to make sure that you're not missing studies. Next slide. So that brings us to the next step, which is screening articles. So at this point, you've received the results from your search from your librarian. Next slide. And your job is to go through screening. This is typically done in two stages where there are two reviewers, typically, who will first go through titles and abstracts. And then in the next stage, they've taken the studies that had relevant titles and abstracts, and then you go through the full text and review those to find the studies that meet your inclusion or eligibility criteria. Sometimes this is done in 3 stages, where titles are the first stage, then abstract, then full text. That's typically done if you have a lot of results, so in the tens of thousands of results from your search. And again, the goal here is to be overly sensitive at the earlier stages. You need to have a plan for disagreements between your 2 reviewers. So no systematic review should ever be published with only 2 authors. The minimum you need is 3, because you need somebody who's going to be able to adjudicate if there are disagreements in the screening process between your 2 reviewers. Next. It's really important that you keep good track of the reasons for exclusion of studies at each stage, and this helps minimize bias by making sure your study is transparent and your methods are reproducible. Next. And I would suggest using structured software rather than using something like EndNote or Excel. I've put 2 examples here that I've used, Distiller and Covidence, both excellent for helping to manage your screening process, and keep track of your exclusions. Next slide. So your screening is going to be judged based on this, which every systematic review should have. This is your Prisma flow diagram, which shows at each stage how many studies were excluded. And I don't have a pointer, but you'll see at the full text exclusion phase, you should also be including in your Prisma flow diagram the reasons for exclusion and how many studies were excluded for each reason. Next slide. And to take that a step further, really the ideal thing to do is for the full text screening having an appendix that actually annotates each of the citations that were excluded and the reason for exclusion. And you don't see this in every systematic review, but certainly you'll see this in some of the higher quality reviews that are published. Next slide. And so if you are a reviewer, really the thing you want to look at in this stage is whether the study selection process was reproducible. By reading the manuscript, do you understand what was done and why studies were selected or excluded? Next slide. That brings me to bias assessment, which is, as the name suggests, looking at the studies that you've selected and assessing the risk of bias. Next slide. So for readers of systematic reviews, this figure will look familiar to you. This is the result of the Cochrane risk of bias tool, which is the most commonly used risk of bias tool for randomized control studies, where each study that you've included in your review is assessed across various domains for the risk of bias. And again, this should be done by 2 reviewers and published as part of your manuscript. Next slide. Next. But the Cochrane risk of bias tool doesn't apply to every study type. So some of you are going to include studies in your systematic reviews that are not RCTs. And some of you are going to include single arm studies. And so you really need to make sure the risk of bias tool you're using is appropriate for your study type. So the Robbins Eye tool, the Newcastle Ottawa Quality Assessment Scale are 2 examples of tools that can be used for cohort studies. The Institute of Health Economics Quality Appraisal Checklist can be used for single arm studies or even case reports. Next. The other thing you want to consider is you don't just want to do a risk of bias assessment, but also consider upfront how you're going to use the information. And I see this commonly, you know, people just have a checklist of what they think needs to be in a systematic review, and they check that they've done a risk of bias assessment. They present the results of it, but never actually comment on it or use that information in any kind of way. And so one element of this is actually reporting on the risk of bias, but also in your discussion, reporting on how you think the bias may have influenced the results of your study. You also have the option of doing sensitivity analyses, such as excluding studies that were at high risk of bias if you're doing a meta-analysis and seeing whether that changes your results, or stratification, where you run your meta-analysis stratified by the results of your risk of bias assessment. Next. The other thing not to forget about is assessing for publication bias, and this is often done with funnel plots. And the recommendation that's made is that if your systematic review includes more than 10 studies, that you do create and report a funnel plot to look for publication bias. Next slide. As a reviewer, you want to be assessing what tools were used, as well as I mentioned, how was that information on bias utilized. Next. This brings us to the data, both the abstraction as well as how you want to present data. Next. So as you think about the data, the first thing you want to think about is what data are important to you. What variables do you want to be collecting? And here you think both at the patient level, what information do you want to collect about patients, but also at the study level. And I'll show you an example of that. Next. But you also want to consider how you're collecting data, because the last thing you want to do is have to go back multiple times to your primary papers to recollect data. So if you are planning a meta-analysis, I would suggest at the outset being very exhaustive in your data collection. So collect point estimates, confidence intervals, p-values, number of events in each group, what the follow-up time was. And sometimes I see people mixing means and medians in various studies. So be very careful about how you're recording and how the actual original study is reporting some of these effect estimates. Next slide. So you're going to report your data abstraction process probably in your table 1 or table 2. Next. And that should include here, I've highlighted, sorry, go back, please. On the left side, you see study level characteristics. So where was the study conducted? When? How was the study done? Next. And then on the right side, you see the patient level characteristics relevant to each study. And these can be reported in a single table or in separate tables. Next. Next. And as you think about reporting data, this is going to differ depending on whether you're doing a meta-analysis or not. So if you're just doing a systematic review, and typically you're doing a qualitative review, what you want to do is you report data, summarize the data in aggregate in your text of your review, and make sure that it concurs with the tables that you're presenting. Next. But if you're doing a meta-analysis, then what you want to summarize in your text are actually the effect estimates that you're getting out of your meta-analysis, not just reporting narratively on the aggregate data. Importantly, if you're doing a meta-analysis, both of those things are important. So your text shouldn't just review numbers and quantitative effect estimates. Next. And as a reviewer at this point, as you're reading the results, what you're thinking about are these data ready for clinical application? Next. This is probably what a lot of people spend time thinking about, the meta-analysis, which is the quantitative combination of the data that you've abstracted. Next. Next. And as you think about the meta-analysis, the effect measures are going to depend based on the type of data you have. So if you have dichotomous data, you're comparing two groups, looking at proportions of events between groups. These are your choices, really. You'll often see risk ratios or odds ratios being meta-analyzed. In the minority of cases, there'll be risk differences or numbers needed to treat that are being reported. Next. If you have continuous data, ways to present those data include mean differences, standardized mean differences, or ratios of the means. Next. If you have time to event data, probably the most common way to combine time to event data is by meta-analyzing hazard ratios. That's not the only way, though. You can pick a time point and report proportions of patients experiencing the outcome. For example, you can meta-analyze the proportion of patients who were alive or disease-free at 2 years. So you can meta-analyze 2-year overall survival, for example. Next. And as you're thinking about effect estimates and effect measures, there are a few things you want to think about. How you're going to weight the effect measures from each study, and we'll come back to this. If you have rare events, particularly in the event of 0 events in certain groups, so let's say you're looking at a rare outcome. I did a study where we were looking at the incidence of C. diff after bowel prep, and there were various groups where there were 0 events observed. You need to know how your statistical analysis software is handling 0 events. For example, if you use RevMan, it actually applies a correction factor to each of the groups that have 0 events. So you need to be aware of that. You do need to consider heterogeneity, and again, we'll come back to that. And another mistake I see commonly made is people combining data from randomized trials and observational studies or non-randomized data. For most of our purposes, that shouldn't be done because of the difference in the nature of the studies and the degree of heterogeneity between the studies. And so if your review includes both randomized trials and observational or cohort studies, meta-analyze those studies separately, and that's often the best technique to use. Next slide. So I want to talk a bit about the differences in heterogeneity. So first, the thing you should be assessing for is this issue of clinical heterogeneity. And from this, if you're reading a systematic review, you can get a sense of this in the tables and figures. So I've put a table here showing 2 different groups where the author is reporting on who was administering the drug, what the doses of the drugs were. And what you get from this table is how the doses and the administrators differed from study to study. This is an example of clinical heterogeneity. How does the clinical environment, the way the interventions were given, differ from study to study? If your studies are too clinically heterogeneous, they should not be combined in a meta-analysis. And so you always have to look at the degree of clinical heterogeneity. This also helps understand why you may have statistical heterogeneity. Next slide. So statistical heterogeneity is a different issue. Statistical heterogeneity refers to how different or how similar the effect estimates in each study are. And one way to assess for that is visually. So this is a forest plot, which is often how data from meta-analyses are reported. And what you want to do as you're looking for statistical heterogeneity is look at the confidence intervals from each of these studies and evaluate whether they overlap. So here you see the confidence intervals, or the arms around the boxes, don't overlap in many of these studies. And that's an indicator that there's a lot of statistical heterogeneity. Next. You'll also see at the bottom of a forest plot some of these numbers, I-squared, p-values, chi-squared, and I'm going to show you what those mean, but those are all measures of statistical, not clinical heterogeneity. Next slide. Next. So the chi-squared value is actually measuring whether the differences you're observing in your results are compatible with chance alone. Next. The p-value, what you're looking at when you have a low or significant p-value, it's telling you that there is statistical heterogeneity in your intervention effects. Next. And the I-squared is actually giving you a percentage of the variability that you're seeing that's due to heterogeneity itself. Next. So when you do have heterogeneity, you need to think about whether it makes sense to do a meta-analysis. That should be the first consideration. Next. The next thing you can do if you decide it's reasonable to do a meta-analysis is explore the heterogeneity. You can do this with subgroup analyses, sensitivity analyses, or meta-regression. Next. As I mentioned, you can do sensitivity analyses. One that you might commonly see is called leave one out sensitivity analysis, which is redoing the sensitivity analysis iteratively, removing one study at a time to see which study is driving your heterogeneity. And then reporting on why that might be. Next. And then finally, you might think about using alternate effect measures or alternate outcomes that are less clinically heterogeneous between studies. Next. So you often hear these terms fixed and random effects meta-analysis. What those refer to is the statistical way that the studies are being weighted and combined by your software. So in a fixed effects meta-analysis, the assumption you're making is that there is some underlying true intervention effect, and all of the studies are estimating the same effect. Next. In a random effects meta-analysis, what you're assuming is that there is heterogeneity in the treatment effects, and each of the studies are estimating similar effects, but not the exactly same effect. And those similar effects fall along a curve. And so you can think most of the studies we do have some amount of heterogeneity. And so it's not a carte blanche statement, but usually what you want to do is a random effects meta-analysis. And I would say in surgical literature, there are very few reasons to do a fixed effects meta-analysis. Next. I think this is very important because a lot of studies I see tell me that the authors write that they selected fixed or random effects based on the I-squared value. The Cochrane Handbook clearly states that you should not choose between fixed and random effects meta-analysis on the basis of a statistical test, such as the I-squared. And so be very careful in making that determination based on low-powered statistical tests. This decision that you make should be based on clinical judgment and assessing the clinical heterogeneity between the studies. Next. And so as a reviewer, what you want to consider is, did it make sense to combine the data in a meta-analysis? What was the degree of heterogeneity and how did the authors address that? Next. And then finally, the last step is thinking about your publication and how you want to write up the manuscript. Next. So this is where Prisma becomes important. So Prisma is a statement that's been put out on how to report a systematic review. There's also an extension statement. There are separate Prisma statements for network meta-analyses, for protocols, for individual patient data meta-analyses. So this is definitely something that you should look at as you're writing your paper. Next. And most journals now require that you submit the Prisma checklist, which details on which page you have addressed every element detailed in the Prisma guidelines. You should have this in front of you as you're writing your paper. Don't just think about it at the end, because this will really help govern how you write your paper. It has good suggestions for what each of your subheadings should be, and it really makes it easier for your reviewer to follow the study. Next. And so as a reviewer, you should be thinking about, was there structured reporting guideline used, and has that checklist been provided? Next. And so my parting advice to you all is probably the best way to ensure that you're doing a high quality meta-analysis or systematic review is to find some high quality studies published in journals that are in your topic area of interest, and try and model your paper or your study based on what you're seeing. And I would say probably the most useful resources are that Cochrane handbook and the Prisma checklist, but make sure you know which to use and when. Next. So that's all I had to say. Hopefully we've left some time for discussion, and my email address is there if anybody has any specific questions they want to send my way later.
Thank you, Fahima. It was really, really great. And I'm sure a lot of people learned a lot. I personally, as always, learn a lot with your inputs here, and I honestly envy the ability to dealing with these, because it takes a hard work to look at those. I have a few questions for you. I'm not sure whether there are more people asking questions on the chat, or maybe raising their hands, or how this is going to work. Emma, maybe you can help me with this. I'm gonna make you myself a question, Fahima. So if I understand correctly, and I was really thinking about the heterogeneity issue, and the statistical heterogeneity, which is something that interests me a lot. So whenever we look at the forest plots and we see, number one, a p-value that is statistically significant, number one, it indicates that is significant heterogeneity. And if the I-square value is high, it means it's probably true heterogeneity rather than chance, correct?
Yeah, I mean, the caveat being that a high p-value doesn't necessarily indicate that you don't have heterogeneity. If you think about a randomized trial, obviously the more patients you have, the more power you have. At the meta-analysis level, you have to think about studies like patients. So if you have 5 studies, it's like running a trial with 5 patients. And so you have very little power when you do these statistical tests. And people will often even use a cutoff for a p-value of 0.1 when they look at statistical heterogeneity. But I would say, like, I almost completely ignore those statistical measures because I don't think that they help very much.
But then so my question is, and I've understood very well the idea that you shouldn't use a fixed versus random effect to run your statistical analyses based on the heterogeneity. You should judge clinically whether one or the other should be used. The point is, so when if you ran your study and you have 10 studies, and you still have a lot of heterogeneity going on with a very, very significant p-value, and I understand the point of using less stringent criteria for the p-values here, and then you see a high I-square value. So at the end of this, so what you're saying is, well, we're seeing this, but it doesn't really mean that we're looking at this is not going to be useful because it's probably too much heterogeneity in the first place, right?
Yeah, or it might be an indicator for you to explore the heterogeneity, right? So you can imagine if you see a lot of statistical heterogeneity, it might compel you to do subgroup analyses where your subgroups are based on the year of publication or the era of publication, or do a meta-regression. So when you do these subgroup analyses or meta-regression, you want to be looking at study level characteristics, but you might say, you know, I think that there's a difference between how patients are treated in the East versus the West. So you can use geography, you can use time periods, you can use these study level characteristics, and then you can look at how heterogeneity changes as you do these subgroup analyses.
Okay, so the end of the story would be me looking at, as a reviewer or even as a reader, if I see such significant heterogeneity with a very significant p-value and a very high I-square value, it means that we should be seeing something that the authors did, trying to assess this either by leaving one out or going back through the studies to trying to understand why this is happening, and maybe try to solve the problem, even though it might not be a problem in itself.
Yeah.
It might be just that and then at the end of the day, it could be that, you know, your meta-analysis, you know, it's quite frustrating that having done all this, getting towards the end of what you did, which is a lot of work, you find out there's too much heterogeneity and it's not worthwhile publishing. Is that true?
Yeah, I mean, that might be true. My expectation, it sounds like you have a higher bar than I do. When I review these studies, what I look for is that the authors have at least acknowledged the heterogeneity. I think that that's the least you need to do. And not just say the I-squared was so-and-so indicating a high degree of heterogeneity, but actually commenting in the discussion on what the implications of that might be or what the source of that might be, and really using that to temper your conclusions. And I think we probably don't do enough of that.
Well, that's a very good point. Let me see if I get any questions from the chat. If anybody's raising their hands, let me know. One of the things you mentioned in the beginning of your talk was to peer review, one of the initial steps. Can you elaborate on that a little bit? I'm not sure people really are used to doing that. I don't often see that on the reported and the submitted manuscripts for systematic reviews and meta-analysis. Can you elaborate a little bit on that?
Yeah, so there are two ways that you can do peer review before you actually publish your study. One that you might see and that I've done a couple of times before is to publish a protocol. So not just registering your protocol, but there are journals that will publish protocols for cohort studies, for RCTs, but also for systematic reviews. And those all go through peer review. I think the nice thing about that is you get a publication out of it. It's probably not going to be cited except by you, but it is a publication. The downside of that is that it becomes harder to make amendments as you go along. And so I typically go in the direction of just registering the protocol so that you can amend it. The other way that you can incorporate peer review is by having somebody peer review the search that you do, or ideally that the information specialist does. And that process can also be published. So there are ways that you can publish your search strategy. But I've had librarians just internally also have a search strategy peer reviewed by their colleagues. And then you just report it when you actually write up the manuscript that the search strategy was peer reviewed in a formal way.
Okay, that's very interesting. And my final question would be, so, you obviously mentioned that you should probably come up with systematic reviews and meta-analysis using good quality studies, such as randomized clinical trials and so on. And that's often not the case for surgical diseases. Yourself, you did a meta-analysis on watch and wait and local regrowth, which was clearly something that we still don't have any randomized clinical trials comparing a watch and wait to anything else. Any tips on when there is no such possibility of getting randomized clinical trials, but still a place for a good quality systematic review meta-analysis?
Yeah, I think you first need to consider whether if there could be randomized trials that you are just not aware of. But some of these questions don't and will never have randomized trials. And you can say that in your manuscript and use that as rationale for including observational studies. And the other thing that you can think about, depending on what your true question is you don't always need to have a comparator arm in a systematic review and meta-analysis. So going back to the example of watch and wait, we had analyses in that paper that compared groups who had a complete clinical response to those who had a pathologic complete response. But we also took single arm data and meta-analyzed data from a single arm. And so some of the studies that were included in that are probably more case series than anything else. And so you can meta-analyze and report on single arm data as long as you're aware of the biases that exist in that. The other thing that we did in that paper, and that you might see in some of these like rapidly evolving topics, is including conference abstracts. And that's especially helpful if you know it's a hot topic, but people are just starting to do studies on it. But the way we got around the bias was we did a sensitivity analysis removing all the conference abstracts and showing that it didn't really change the effect estimate, just the precision around it. So those are a few techniques. I think people often assume that you need to be comparing two groups in a meta-analysis, but there are certainly techniques that you can use to meta-analyze single-arm data and just report pooled proportions of a given event.
All right, so we're getting close to 6 o'clock here in Brazil. It's probably 5 o'clock there in the US. I want to thank you again for sparing some time to share with us the expertise. I'm probably going to invite you for a follow-up explanation on all those topics you didn't touch on, and we might want to have a session with you dissecting one of your own meta-analysis systematic reviews that you did to tell us how what the pitfalls are, how you dealt with them, so that we truly become proficient in reading these more frequently published systematic reviews and meta-analysis. Thank you so much, Fahima. It's really a pleasure and a privilege to have you here with us. Thank you so much.
My pleasure. Thanks, everyone.